Welcome to this month's edition of Diabetes, Obesity, and Cardiometabolic Disease Update, a podcast formerly known as Diabetes Core Update Podcast. I'm Dr. Neil Skolnik, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University, and joining me, as always, is my co-host.
Hi, I'm John Russell. I'm Clinical Professor of Family and Community Medicine at the Sidney Kimmel Medical College and Chair of Family Medicine at Jefferson Abington Hospital.
John, we have a great series of articles this month. We sure do. And the first one is from the Annals of Internal Medicine, some startling news. The article is titled National Prevalence of Clinical Obesity by BMI Class, a National Cross-Sectional Study. Then an article from Diabetes CARE titled Achieving at least 15% weight loss within 2 years of type 2 diabetes diagnosis is associated with lower risk of macro and microvascular complications. And then an article from the New England Journal of Medicine on survodutide once weekly for the treatment of adults with obesity. We'll find out what survodutide is. Then an article from Diabetes CARE on the national trends in out-of-pocket costs for glucose-lowering drugs among U.S. adults with diabetes from 2000 to 2022. And the results there are a bit surprising. Then an article from Diabetes CARE on the impact of Finerenone on albuminuria in type 1 diabetes, looked at by baseline A1C, a critically important new medication being studied for type 1 diabetes and renal disease. And then finally, an article from The Lancet on orforglipron compared with dapagliflozin in adults with type 2 diabetes who have inadequate glycemic control with metformin. John, let's jump in, and why don't you tell us about the first article?
Yeah, so the first article is from the Annals of Internal Medicine, actually in their letters section, looking at the national prevalence of clinical obesity by BMI class, a cross-sectional study. So overall obesity defined as a body mass index of greater than 30 kilograms per meter squared or greater than 27.5 kilograms per meter squared in Asian adults. And the point of this study is really saying that BMI alone doesn't fully capture the number of people who have obesity. And in this particular letter that was tied to an article that was in The Lancet, they look at the NHANES study and they look at some anthropomorphic data on top of people having clinical obesity. And what they overall found was of the people who had normal weight, at least 26% of them had one of the anthropomorphic categories that would qualify for them as obesity. The overall excess adiposity, 40% with an abnormal BMI had at least one abnormal anthropomorphic measure versus 77% had 2 to 3 more anthropomorphic measurements, regardless of BMI. The overall adjusted prevalence was lower for preclinical than clinical obesity, and adjusted clinical obesity prevalence increased by BMI class, 26% among those with a normal BMI, 50% for overweight BMI, and 85.3 in class 3 obesity. So overall, takeaway study is there's an awful lot of people who are overweight or obese, and there might actually be more when we look at not that singular note to define obesity. Neil?
John, this study is really remarkable. We know, and we've been saying for a long time, that BMI is not the best measure of obesity. We know that it might overestimate it sometimes in people who are athletes with a lot of muscle mass and therefore have heaviness, but not excess adiposity. That actually doesn't happen very often. And we usually can assess those people and know who they are. But where the bigger concern is under categorization of excess adiposity, i.e., people who have overweight and who actually have excess adiposity, but they don't have an elevated BMI. And this study just brings that home. And I want to focus on that group that you talked about who have overweight and who had 2 to 3 abnormal anthropomorphic measures consistent with obesity. What is that? High waist circumference, a high waist circumference compared to height. What are some other measures? Skin fold measurement can be another measure. And it turns out that for people in the overweight category, as you said, 83% of them, when measured by measurements that are considered more accurate than simply BMI, 83% of them would qualify as having obesity, and among normal weight people, almost 40%. That is just remarkable. And then if we look at that definition of clinical obesity, which the Lancet talked about, that is people who have an elevated BMI and also have end organ damage. What we see here is that for people with obesity class 1, about 70% of people with obesity have some evidence of end organ damage, and of people who have overweight, who would not ordinarily be classified as obese, they have clinical obesity by virtue of having cardiometabolic abnormalities as a result of excess adiposity. What this says is that we really have a lot more people out there with excess adiposity, with clinical obesity, than we even realize. And we know that about 40% of adults in the United States are categorically classified as obese according to the CDC's definition of a BMI greater than or equal to 30. But this data suggests that about 70% or more of United States adults actually have excess adiposity. For our next article, we're going to look at an article from Diabetes Care on achieving at least 15% weight loss within 2 years of type 2 diabetes. Diagnosis is associated with lower risks of macro and microvascular disease. The objective in this study was to evaluate whether achieving a minimum of 15% weight loss early on after type 2 diabetes diagnosis was associated with subsequent lower risk of complications. They looked at a UK primary care data set from the Clinical Practice Research Data Link. This was a cohort study beginning in 2000 up to 2024 of adults with obesity and type 2 diabetes. Individuals with greater than or equal to 15% weight loss within 2 years of their diagnosis were propensity score matched 1 to 4 to control subjects who maintained a stable weight over those 2 years. And then they looked at the rates of micro and macrovascular disease. And this was a large number of people in this trial. I was actually surprised to see how many people they found that had lost more than 15% of their weight. And that was over 14,000 individuals with greater than or equal to 15% weight loss were compared to 57,000 control subjects. And compared with those control subjects, the weight loss group had significantly lower risk of first macrovascular event. The hazard ratio there was 0.86, or a 14% decrease in risk. And microvascular risk showed a hazard ratio of 0.9, that is a 10% decrease, both of which were statistically significant. The weight loss group also demonstrated, not surprisingly, better glycemic and blood pressure control despite being on fewer medicines. John?
So Neil, a really interesting study, and I think the headline is going to say weight loss. And it should really be written the legacy effect, right? So we have played this out so many different ways. And if you look at the people who lost that more than 15% weight, about 80% of them in both the first 2 years had A1Cs that were under 6.5. So, is it completely kind of chicken and egg? So I think one of the things I would potentially take away from this study, and I think often, in primary care, we're often have that kind of emotional connection with people, and we don't want to push them too much, and they're they're having a little grief reaction to being told that they have diabetes, and we don't want to be kind of too push them too hard too fast. But if you could say to people, if you can get your sugar under control, you can get your A1C down, and if you can get your weight down 15%, I can decrease the chance of you having kidney failure, retinopathy, cardiovascular disease related to your diabetes by about 10-15%. But we need to do it now. We need to kind of stop kind of hemming and hawing, and I'm going to try this and I'm going to try that. Okay, well, if you're going to try that, what you really need to work on is really significant weight loss. And we now have medicines in our diabetes toolbox that can help people get better glycemic control and weight loss. And maybe we need to go to that a little sooner instead of that person whose BMI is 40, for that person who's got some of that BMI that we just talked about in the NHANES world. Our next article is from the New England Journal of Medicine, and it looked at survodutide once weekly for the treatment of adults with obesity. So this was a phase 3 double-blind trial that assigned adults with a BMI grade 30 or greater, or 27 or higher with at least one obesity-related complication, in a 1-to-1-to-1 ratio to receive once weekly survodutide administered subcutaneously at a dose adjusted up to 3.6 milligrams or 6 milligrams or placebo, in addition to counseling and lifestyle modifications. The two primary endpoints were the percent change in body weight and reduction in body weight of at least 5% from baseline to week 76. The primary efficacy analysis was conducted according to the treatment regimen Estimand, which incorporates the effect of early discontinuation of the medicine or placebo and the use of protocol published obesity medications. Among 725 participants, there were 241 in the 3.6 milligram survodutide group, 242 in the 6 milligram group, and 242 in the placebo group. The mean age of the participants was 47.1 years, and 40.6 were men. At baseline, the mean BMI was 37.9, and the mean body weight 108.8 kilos. At week 76, the mean change in body weight from baseline, according to the treatment regimen Estimand, was a decrease in 12 in the 3.6 milligram survodutide group. In the 6 milligram group, it was a decrease of 13%. And there was a decrease in 5.4% in the placebo group. 72.6, 71.9, and 46.3% of the participants, respectively, had weight reductions of at least 5%. The most common adverse events were GI symptoms, typically mild to moderate, which occurred in 80.9% of participants in the 3.6 milligram group, 89.7% in the 6 milligram group, and 47.9% in the placebo group. Neil?
John, the important weight loss that occurs with survodutide speaks for itself, so we understand that readily. I want to focus a little bit on the way in which survodutide is different than the GLP-1s and dual GLP-1 GIP agonists that we are familiar with, semaglutide and tirzepatide primarily. And survodutide is different because it includes glucagon. So it's a GLP-1 glucagon agonist. Now, that glucagon agonist aspect might be a little bit surprising to people because we think about glucagon as a hormone that basically increases blood sugar. We give glucagon if someone has hypoglycemia. But when it is in the right proportion, with a GLP-1, it has remarkable properties. And some of the things that glucagon does, in addition to when it's given alone, increasing blood sugar, that glucagon actually reduces appetite so that it does so in addition to the incretin hormones. It also induces lipolysis and it increases energy expenditure. Why that's important is because the increase in energy expenditure may lead to a longer tail of time until a plateau is reached with regard to weight loss. And the increased lipolysis and effect on fat, particularly in the liver, makes survodutide a particularly interesting molecule. And when they did a sub-study here, there are a couple of sub-studies. One focused on liver fat. There was an almost 65% reduction in liver fat. That's important. The other sub-study was one of body composition. And a question is whether or not the addition of glucagon to an incretin leads to a beneficial effect on body composition, and we might see more information on that at another time. So finally, the other thing is that not everybody responds to our current weight loss medicines. We clearly see super responders, we see average responders, and we see poor responders. And it will be interesting to see whether a GLP-1 glucagon agonist might work for those people who are non-responders to our current incretin-based medications. Our next article, which is from Diabetes Care, is titled National Trends in Out-of-Pocket Cost for Glucose-Lowering Drugs Among U.S. Adults with Diabetes from 2000 to 2022. The objective of this study was to examine national trends in out-of-pocket costs for glucose-lowering medicines among U.S. adults who had diabetes from 2000 up until 2022, and the authors analyzed medical expenditure panel survey data that was linked to pharmacy verified records for adults with self-reported diabetes. They looked at out-of-pocket costs per user by medication category and at the population level. The population average out-of-pocket costs declined by 46%. And that was driven by a sharp per user out-of-pocket cost reduction for the older oral agents and decreasing use of human insulin. Out-of-pocket costs for newer agents and analog insulin, of course, remained higher and in fact had surging uptake. John?
So Neil, a little bit of a deceiving article. So hey, the cost of diabetes is going down in the country. So the most expensive chronic disease that we have, $413 billion annually, $1 out of $4 in healthcare, which is probably $1 out of $4 in its own right, is spent on care of someone with diabetes. So tremendously a huge ticket item. The operative word in this whole thing is out-of-pocket expenses. So, and there's many different kind of parts of this. So one is certainly our leaders have really kind of worked on having some more affordable insulins and really putting some caps on insulin and things like that. I think as we have evolved to have more treatment choices, there are people who 20 years ago might have been put on insulin who were put on a GLP-1 or something else right now. And one of the things, some of the newer medicines, so we think about the GLP-1s, we talk enough about the GLP-1s, they've been around for a quarter century. We don't think about that. We think that it's kind of a brand new product. They've been around for a long time. But when they came up out once upon a time, they weren't covered. And it was really hard to prove to a payer to cover them. And then suddenly we have some of the problems with one of the TZDs. We need to do some safety studies to make sure that there's not an increased cardiovascular effect, that we're not going to harm people with all these medicines. And lo and behold, two of the categories have great MACE benefits. So suddenly, it's really hard for a company to deny that someone's going to do better with cardiovascular disease and not let us use one of these expensive medicines. And then the explosion of all the other things that aren't in that MACE category that we have found, from OSA, from fatty liver, from congestive heart failure, from kidney disease, et cetera, that would qualify for someone to qualify for one of these medicines. So if they qualify, people aren't having to pay for this completely out of their own pocket. So I think a lot of the costs are going down from diabetes. Now, some of the bigger costs from diabetes, if we can do a better job and we can get more people under control, we can get A1Cs lower, we can decrease proteinuria. Maybe we can keep some people off costly dialysis. Maybe we can keep some people out of the intensive care unit, et cetera. So I think there are so many things involved in this. We're still spending an awful lot of money on diabetes, but we have kind of figured out some ways to maybe make it a little bit more affordable for the average patient. Our next article is from Diabetes Care, and it looked at the effect of Finerenone on albuminuria in type 1 diabetes by baseline A1C level and diabetes duration. This was the FINE-1 trial. So this study looked at 242 participants, and they looked at their baseline A1C, the mean A1C, diabetes duration, and GFR. So looking at those numbers in the group, the A1C was 7.6%. The duration of diabetes was 32 years, and the GFR was 58.9 milliliters per minute. At 6 months, the A1C remained unchanged, and the Finerenone placebo and between group difference was very small, a positive 0.04%. Over 6 months, the urinary albumin creatinine ratio decreased from 574 to 373 with Finerenone and 506 to 475 with placebo. So that was a 25% placebo-corrected change. Treatment effects were consistent across all A1C tertiles, and placebo-corrected changes, a decrease of 18% and 37% respectively. Effects were similarly consistent across diabetes duration tertiles. Overall safety and incidence of hyperkalemia were similar across the different A1C tertiles. Neil?
John, this is an incredibly important study, the FIND-1 study. And if we think about it, we've had a lot of wonderfully effective medicines come out that slow the progression of kidney disease and also improve cardiovascular outcomes in people with kidney disease and type 2 diabetes over the last few years. And those medicines, in addition to ACEs and ARBs, which we've had for years, include now the SGLT2s, the GLP-1s, and Finerenone. Finerenone trials about 5 years ago, Fidelity and Figaro trials showed both a decrease in the progression of decreased albuminuria as well as progression of kidney disease in people with established kidney disease and type 2 diabetes, and also showed a decrease in cardiovascular outcomes. We know we've seen similar things with the SGLT2s, with the FLOW study of semaglutide. But it has been over 30 years since a medication has come through for people with kidney disease and type 1 diabetes. And this is a critically important issue because eventually about 40% of people with type 1 diabetes develop kidney disease. What the makers of Finerenone did is used the concept of a bridging biomarker. What that means is if we can show an effect on a biomarker in similar populations that have similar underlying pathophysiology, i.e., if we know a medicine works to decrease cardiovascular outcomes and slow progression of kidney disease in people with type 2 diabetes when they're giving Finerenone, and we know that affects a decrease in UACR, if we can show that decrease in UACR in people with type 1 diabetes and kidney disease, we can presume a similar effect on decreasing progression of kidney disease and decreasing cardiovascular outcomes without doing the very large trial that takes a long time and thousands of people enrolled. That concept is used in a lot of different therapeutic areas. And so it was used here. So we have the data from Figaro and Fidelity. We've talked about it on this podcast a few years ago. We have the large FINE-1 trial that was reported earlier this year in the New England Journal for people with type 1 diabetes and kidney disease. And the current sub-analysis of that trial shows us that across A1C categories, across levels of duration of type 1 diabetes, that Finerenone substantially decreases UACR, and by extension, very likely will decrease the rate of progression of chronic kidney disease and possibly even cardiovascular disease in people with type 1 diabetes. Let's now go on, John, and talk about our last article of this issue. And the title of that article from The Lancet is Orforglipron compared with dapagliflozin in adults with type 2 diabetes who had inadequate glycemic control with metformin. This is the ACHIEVE-2 trial. This study assessed the efficacy and safety of orforglipron, which is an oral non-peptide GLP-1 receptor agonist, versus dapagliflozin, which is, of course, an oral SGLT2 inhibitor in people with type 2 diabetes who were inadequately controlled on metformin. This was a 40-week phase 3 multi-center open label double-blinded randomized study. The study included adults with type 2 diabetes using metformin greater than 1,500 milligrams a day with an A1C between 7 and 10.5%. Participants were randomly assigned in a 1-to-1 to 1-to-1 ratio to receive once daily oral orforglipron, 3 milligrams, 12 milligrams, or 36 milligrams, or DAPA, 10 milligrams. And the primary endpoint was changed from baseline in A1C at week 40. There were over 960 participants randomly assigned to Orfo 3 milligrams, 12 milligrams, 36 milligrams, or DAPA 10. Mean age was 56 at baseline. Mean A1C was 8.14, and the mean BMI was 32.5. At week 40, all orforglipron doses were non-inferior to DAPA in reducing A1C, and the change from baseline in mean A1C was negative 1.2%, negative 1.5%, and negative 1.56% with orforglipron, 3 milligrams, 12 milligrams, and 36 milligrams respectively, versus negative 0.81% with dapagliflozin. All of these had a p-value less than 0.0001. The most frequent adverse events associated with orforglipron were mild to moderate GI events. John?
So a little bit this has been a little bit of the holy grail we've been kind of waiting for. We're very excited with GLP-1s, and I think we're excited for a couple different reasons. For GLP for A1C reduction, really, really good. And we think about it in that 1.5 to 2 range that you're seeing at the 2 higher doses here. The GLP-1s are great for weight loss, and we're seeing people in the 2 highest groups in that 6 to 9% weight loss area, which is pretty exciting. And there's some other studies that have had higher weight loss with this medicine. So the ability to harness some of the powers of a GLP-1 without having to do an injection, without forsaking quite as much of the weight loss. Comparing it to the oral semaglutide, it doesn't have the restrictions on having to take it on an empty stomach, when not drinking anything around the time of using it. So exciting to see kind of how this plays itself out, and and kind of real world evidence is something that we become real excited about, because you certainly kind of studies with kind of smaller numbers of people, and suddenly we're using this on 1 million people. Be very interesting to see kind of how well it does. Comparing it with dapagliflozin, it's not news to any of us that dapagliflozin doesn't really have the A1C reduction. Not news to us that dapagliflozin really doesn't have the weight loss to that. So not necessarily kind of big news on that, but very encouraging news on using this new medicine in its 3 doses. And certainly at the highest dose, we're really seeing the fullest of benefits.
And John, that concludes our issue for this month. Another great issue with lots of new information that we can use beginning tomorrow. For our listeners, remember we have renamed our podcast from Diabetes Core Update to Diabetes, Obesity, and Cardiometabolic Disease Update. That's why you will see a change in the icon associated with this podcast to DOC Update. That's Diabetes, Obesity, and Cardiometabolic Disease. Quite clever there, I must say. So till next month, for John and I, and for everyone at ADA, keep listening and keep learning.